Mariano.
Thank you very much for Aaron Ali for your kind invitation. Uh, this procedure is not totally new for me because I work in this area in the last 30 years. And I am HPV surgeon, but I am a fellow of the Society of Interventional Radiology, a member of the European and American Society of Interventional Radiology since 1996. Is possible the union? Yes, it's possible because it's not important. We are surgeons, we are radiologists. It's important our patients. The logic of department of the surgery, etc., is in 19th century. It's not applicable in this century. In this century, is our focus is our patients, not us. Is my opinion. Well, now I talk about the biliary tree for benign and malignant indication, nothing to disclose. The evolution and the surgery during the last century was the interventional radiology, laparoscopic surgery, endoscopic treatment, or the idea of a minimal invasive surgery. With the evolution of this century was a robotic, imaging guide surgery, artificial intelligence. This idea is not the idea to replace the minimal invasive. It's complementary to the minimal invasive surgery, but it's the same way, and it's a very important thing to work in this area. The percutaneous image guide surgery is not only high quality images, it's a navigation system, use augmented reality, and of course robotic and artificial intelligence in the near future. About the axis of the biliary tree, we use right or left side, of course, bile for culture, and introduce the guide wire and 4 French catheter to introduce the guide wire and catheter into the intrahepatic bile duct. In more complex cases, we have the necessity to cross the stomach to introduce a catheter in a specific patient, only 2 or 3 in my life because it's more complicated, but it's possible to use this access to drain the bile duct. It's a very important thing, the knowledge of the disease and knowledge of the different procedures. And in the idea of the dilated biliary duct is better to drain of a percutaneous approach, and non-dilated is better to endoscopic approach. It's not true because we have a lot of benign disease with not dilated intrahepatic bile duct, and it is possible to drain. In that patient, we use the portal vein, and near to the portal vein is possible to access to the bile duct and introduce a needle and the catheter. More and more, we use only one approach, left or right, not 2 or 3 catheters, and use articulated catheter because the risk of complication, for example, bleeding, increase proportionally to the number of point of access. For example, in this case, we use here the articulated catheter to drain with only one access, the right and hepatic branch. In more complex cases, for example, in this case, secondary to the liver transplant, we use multiple articulated catheter. It is more complicated, but the idea is with only one access, we have the possibility to drain all the liver. This is a very important and interesting thing. The use of percutaneous imaging guide surgery in biliary benign disease. Well, in case of bile duct stone, of course, the first option of treatment is endoscopic treatment, but in case of this is impossible, we use at this moment the anterograde papillary balloon dilation, because at this moment we don't remove the stone. We, for example, in this case, with the stone, we dilate the papilla with the balloon and flushing or move the stone into the duodenum. The other thing is drain patient with little laparoscopic problem. For example, in this case, well, the idea is stabilize the patients and make definitive treatment in better condition. But we have the possibility to make a definitive treatment in patients with no total stricture in the bile duct secondary to the bile duct injury. For example, in this patient with leakage, the bile leakage, we introduce a catheter into the bile duct, not dilated bile duct, and later we place the balloon with balloon dilation with these final results. Or in patients with leakage in the right hepatic lobe, we introduce a catheter and later the balloon dilation. Or in more complex cases with totally broke the right hepatic duct, we have the possibility to reconstruction, a percutaneous reconstruction of a bile duct and secondary balloon dilation, of course, because the cure is with a stricture and with these results. Or in this case, 11 years old patient with a symptomatic stone, with pediatric surgeons perform laparoscopic cholecystectomy with bile leakage in the post-operatory period. With this fistulography, the pediatric surgeon said, well, it's all okay. The problem is a cystic duct, but really it's not true, because in this MRI is possible view the problem is the right hepatic branch here, the right hepatic branch. Well, the idea with this patient was the idea to treat totally for a percutaneous route. It's not necessary in all cases the hepaticojejunostomy with the right branch. For example, in these patients, we place the guide wire into the right side. From here, of course, the guide wire was not to the choledochore, was to the subhepatic drainage. We introduce the guide wire into the catheter through the hole of the catheter, and we remove the catheter with the idea of this is through the skin, the guide wire into the right hepatic lobe, and set from here the subhepatic. Well, with the idea to reintroduce the guide wire, I introduce the guide wire into the choledochore. The idea is this, and this, and this. And later, for example, introduce the guide wire here to the skin, to the bile duct. This is to the collection, and reintroduce the guide wire with this idea, with this result, with the idea of a percutaneous balloon dilation and this final result. Of course, the follow-up of this patient is only 1 year. We need a lot of months for the success rate, but we have a patient with more than 20 years of a follow-up with this technique. The other thing is work together with the endoscopies, a rendezvous technique. For example, in this case, with 2 clips in the bile duct, was totally impossible to cross the percutaneous access. Through the endoscopic route was possible to cross, but was impossible to dilate it. For that reason, we catch the guide wire here. The idea is the guide wire from the mouth and from the right side of the skin, and later we introduce the balloon and partially open the clips now, and this is finally open the clips. In case of a stricture of the hepaticojejunostomy, we introduce a percutaneous drainage and balloon dilation. The problem with the balloon dilation, with this result, the problem with balloon dilation is the possibility to failure. In case of failure, at this moment, we perform a sustained dilation. We introduce 5 to 7 plastic stents through the hepaticojejunostomy, with the idea for 4 to 5 months through the left side. For example, here is 5 catheter, and or possible to the right side from here, or in more complex cases, bilateral through the left and right side. the success rate is 80% of success in the long follow-up, and this is very similar to the new hepaticojejunostomy. But it's a very complex technique. For that reason, at this moment, we use the polydioxanone biodegradable stent, is the PDS stent. In case of double stricture, we use 2 biodegradable stents. This is a follow-up of 78 months on these patients. And we have, this is our paper and different center in Europe and our center in Buenos Aires with more than 100 patients with benign biliary stricture. At this moment, our success rate is 84%, but the follow-up is only 2 years. We need more time. But the most important thing with the biodegradable stent, in case of failure, is possible perform a new hepaticojejunostomy with no problem. Finally, in the biliary malignant, well, we use the percutaneous access. We introduce the guide wire into the bile duct, and we introduce, in case of failure endoscopic route, one stent, but more and more we use these procedures in the upper part of the bile duct, and we use a multiple stent with this shape, or in T, or in typical we use at this moment this lily shape with 1 stent distal and 3 stents into the first one. The technical is more complex and need 4 stents, it's more expensive, but this is the final result with this multiple stent. Finally, duodenal obstruction, we make a different route, different approach. Oral is similar to the endoscopic, but it's possible use all radiological, but in my opinion is better the endoscopic route. But in patients with malnutrition, we use through the gastrostomy, and we introduce, for example, in this case, in the previous biliary stent, we introduce the duodenal stent, and through the stomach, the transgastrostomy, jejunostomy for eating. And it really is a very interesting thing in malnutrition patients. And finally, in case of simultaneous biliary and duodenal obstruction, it's possible introduce both stent by endoscopic route, but in our opinion, it's more easy to introduce all the stent, the biliary and duodenal, through the transhepatic route, transpapillary. For example, in this patient with this obstruction and the obstruction of the duodenal obstruction, we introduce the duodenal stent through the transhepatic route, and later the biliary stent in the same moment. In case of the stricture is proximal, we use the same access through guide wire, one through the papilla, the distal to the biliary stent, and the second one in the stomach, we introduce the duodenal stent. Really, we don't use, in this case, duodenal stent, we use really colonic stent, because it's in different position. It's a technical aspect, it's not important for this talk. And this is a final, we open the duodenal stent, and finally open the biliary stent. Thank you very much. It was a long talk about the different possibilities to use the percutaneous surgery in the problem in the biliary tract. Thank you.